Well, good morning, good afternoon, and good evening to all our friends and colleagues around the world. I, Dr. Prashant Bhasin, the chairman of the International Cooperation Committee of the Global Summit, gives a very warm welcome to our today's international speaker, a great mentor and a great guide, Dr. Sonia. Dr. Sonia, welcome to our Podina session, ma'am.
Thank you very much, Dr. Prashant.
It's a pleasure and honor for us that you have taken your valuable time today and you have actually spreading a topic which is, I think, which will open a different horizons for us. But yes, you have been into the field of dentistry probably more than a decade or so. And I think you have changed the era of the dentistry, changing from a pre-COVID to the post-COVID. So we would like to understand and we would like to know your experience, how it has changed in last 2 years.
Right. First, I would like to thank you for hosting my webinar, and I'd like to thank the Global Summit Institute for this opportunity. As to your question, I feel that pre-COVID and post-COVID, dentistry has actually had a big shift, and especially related to networking and integration of healthcare professionals as a team, which is the topic I'm going to be talking today. I found that because we're more on Zooms and we're meeting more doctors had more time. I'm finding this integration of new healthcare providers and the communication has actually improved, opening up a big channel for doing what I'm going to be proposing we do today, which I think is the future of dentistry and healthcare altogether.
Great. Well, thank you for your deeper insights on the newer horizons of the dentistry post-COVID. So before we go ahead with the very informative session today by Dr. Sonia, I would like to share some credentials with you all. Dr. Sonia is an internationally acclaimed expert in a minimally invasive facial and dental aesthetics procedures. She has 3 decades of the international experience using laser biotechnology in the UK, Brazil, and the United States of America. She successfully runs 2 training academies from Dallas. One is the International Laser Academy and the American Academy of the Orofacial Harmony. She is also actively involved in the craniofacial sleep medicine at the Village Wellness Institute, Sao Paulo, Brazil, and at 2 sleep medicine centers in Dallas, with a holistic approach to the orofacial harmonization. Frontrunner on lasers and photobiomodulation in dentistry in UK and Brazil. She has a master's degree from the Eastman Dental Institute, London, UK, and continuously do research and publications in the area of lasers in the cooperation with the 2 major international affiliated universities, that is the University of Sao Paulo, Brazil, and De Montfort University, UK, from which she is currently working towards a PhD in lasers in biomedicine. Dr. Sonia is a current president-elect for the Group Pharmacology, Therapeutics and Toxicology Group of the International Academy of the Dental Research. She is a counselor of the AADOR, as in both committees, and the IADR Task Force of ADA Committee Working Group for the Development of ADA Standards of Dental Lasers. She was guaranteed the Top 100 Doctors Award in the dentistry in 2020, has several publications, and is on the editorial board of some major peer-reviewed dental journals. Such a vast experience of you, ma'am. It's really amazing for us. And I welcome you all to deliver your great talk with us. Ma'am, the floor is all yours. Please kindly share your presentation.
Thank you. Thank you. I should have left on. Okay, so today I'm going to be talking about, can you hear me okay?
Yes, you are audible.
Okay, thank you. Today, I'm going to be talking about the integrative oral medicine and the new trend. First, I want to make a disclosure that I have no financial conflict of interest on what I'm going to present today. So what's integrative orofacial medicine? Dentistry was first described in 2600 before Christ. It was found in the tomb of Hezhe, an Egyptian scribe, as the first inscription, dentist, the greatest of those who deal with teeth and of physicians. In the Middle Ages, dentistry was represented by a guild of barbers in France, which evolved into two groups. The surgeons who were educated and trained and performed complex surgical operations, and the lay barbers who performed routine hygienic service, including shaving, bleeding, and tooth extraction. In the 18th century, Pierre Fouchot, a French surgeon, was nominated the father of modern dentistry. The 20th century saw great innovations in technology: the water fluoridation and fluoride toothpastes, the development of acid etch technique, bonding agents, and composite resins, the development of lasers, osseointegration of dental implants. The 21st century is the era of digital dentistry, of artificial intelligence, cloud dental records, and integrative healthcare. Some of us are still mainly treating teeth. It's time dentists also move into this new era. Integrative orofacial medicine is a way to move forward. We now have become doctors of head and neck. The National Center for Complementary and Integrative Health new strategy plan for fiscal year 21 to 25 expands the definition of integrative health to include whole person health, aiming at improving people's health in multiple interconnected domains: biological, behavioral, social, and environmental. The plan attempts to better define and map a path to a whole person's health. The National Center for Complementary and Integrative Health from the National Institute of Health also recommends that evidence-based complementary therapy should be integrated with and not used as an alternative to conventional medicine. If a non-mainstream approach is used together with conventional medicine, it's considered complementary. If a non-mainstream approach is used in place of conventional medicine, it's considered alternative medicine. The term functional medicine is used to describe integrative health or sometimes for naturopathy. Integrative medicine is the association of conventional medicine and complementary approaches together. Integrative health and wellness utilize multimodal interventions, conventional plus complementary health approaches in a very coordinated way. It emphasizes the treatment of the whole person rather than focus on a single organ system. It uses well-coordinated care with different healthcare providers. The use of integrative approaches to health and wellness has grown across the United States. Researchers are currently exploring the potential benefits of integrative health in a variety of situations. For instance, in pain management for military personnel and veterans, relief of symptoms in cancer patients and survivors, and programs to promote healthy behavior. Light and electromagnetic devices, for instance, are classified as complementary medicine and fall under the physical and psychological wellness category, as you can see from the graph. For us, dentists, one example would be the use of photobiomodulation therapy to treat various conditions to promote an integrated approach to health. The way we, as dentists, can incorporate oral medicine into our practice is to use well-coordinated care with different healthcare providers and integrate complementary therapeutic approaches to our daily routine. We need to stop being isolated dentists and build a working team with our healthcare community, using a good and regular communication channel, not only to refer our patients to each other, but also to coordinate our patient care in real time. We can build a team with the head and neck surgeons, the chemo and radiotherapy center, the psychiatrist, the myofunctional therapist and speech therapist, nutritionist, buccomaxillofacial prosthetic reconstruction dentist. We can include psychologists, chiropractitioners, osteopaths, integrative or functional medical doctor, ear, nose, and throat doctor. We as dentists can take the lead as the core provider in many fronts that involves the need of our services. Many diseases and syndromes are first manifested in the oral cavity. We are on the heart of the correlation between periodontal disease and systemic conditions such as cardiovascular disease and others. In oral cancer, for example, we can work in coordination with the head and neck surgeon prior to removal of the oral cancer by making the obturator in advance whenever possible, so the patient can have their prosthetic appliance fitted in the immediate post-surgical, avoiding the need of oral intubation for feeding. We can also intervene in the post-surgical by construction of the oral nasal obturators or construction of a dental prosthesis that will allow the patient to eat better, coordinating with the speech therapist, who will check for any nasality left with our prosthesis. The team involves other specialties that takes care of the patient as a whole, such as nutritionist, the integrative medicine doctor, the psychologist, and whichever other specialty we find necessary to add to the well-being of our patient. There are so many areas where complementary health approaches can be incorporated into our daily routine. Thanks to photonic biotechnology, light and electromagnetic devices opened up a large field of opportunities from the areas of diagnostic with fluorescence to the treatment of condition with photobiomodulation therapy. We play a fundamental role in the early detection of oral diseases, such as periodontal diseases, caries, and oral cancer, all of which can be enhanced with the aid of fluorescence. Light technology can be used to detect and treat disease in real time. For example, fluorescence can be used to visualize biofilms in tooth and implants. Recent research have also made it possible the use of fluorescence to guide cancer surgery in real time, allowing for minimal reduction of tissues. We are the providers of early detection of oral cancer, preventative and curative treatment of oral mucositis and xerostomia caused by chemo and radiotherapy of patients with head and neck cancer. Now, the randomized clinical trials have pointed to that oral opioids are not more effective than other drugs in control of pain. Authorities are supporting the use of and development of alternatives for pain relief. Evidence-based literature supported use of photobiomodulation and lasers in the prevention and management of pain. We can use photobiomodulation therapy, for example, to manage acute pain and to offer comfort for many patients with chronic pain conditions, such as trigeminal neuralgia and other orofacial pain disorders. There is a large body of evidence supporting the efficacy of low-level laser therapy or photobiomodulation therapy for the management of mucositis in patients undergoing radiotherapy for head and neck cancer. And it's now the gold standard of care for this condition worldwide. Photobiomodulation can be used in all phases of care for mucositis and xerostomia, during and post-surgical procedure to produce pain and accelerate healing, prior to chemo and radiotherapy to prevent oral mucositis, post-chemotherapy to increase blood flow in the area and prevent necrosis, increase salivary flow, and to prevent, control, and treat oral mucositis and xerostomia. We dentists start with the prevention irradiation protocol before the patient undergoes the chemotherapy, and all the sessions thereafter are also carefully coordinated with the chemotherapy center and the professionals involved. Again, this required careful coordination between caregivers. We use a similar team approach in sleep medicine. We are also the core solution for consequences of sleep-related disorder breathing caused by craniofacial underdevelopment. Why and how? The American Dental Association issued a policy in 2017 policy statement addressing the role of dentistry in sleep-related breathing disorders. The adopted policy emphasized that dentists are the only healthcare providers with knowledge and expertise to provide oral appliance therapy. They stated the influence of sleep-related breathing disorder on potential serious medical conditions associated with obstructive sleep apnea, such as metabolic, cardiovascular, respiratory, dental, and other diseases. They outlined the role of dentists in treating sleep-related breathing disorders. They recommended that dentists assess patients' risks for sleep-related breathing disorder as part of a comprehensive medical and dental history and refer affected patients to appropriate physicians. Dentists serve as a front line to proper screening and education, and therefore can change the course of healthcare forever. The goal of an airway collaborative network, for instance, is to tackle the root cause of a deficiency and compensated human airway. This approach is a shift to the orthodox paradigm that uses specific techniques for treating signs and symptoms of conditions and not the etiology. Healthcare professionals together need to find the common cause behind the medical concern of their airway patients. Their visible symptoms need to be investigated with multidisciplinary approach. We need to do a whole body health and wellness assessment, which will include a sleep study. We now know that there are a variety of health risks associated with this sleep and breathing disorder that may be resulting from underdeveloped jaws, such as headache, migraines, bruxism, mouth breathing, snoring, allergies, asthma, ADHD, bedwetting, chronic fatigue, aggressive behavior, anxiety, depression, dementia, hypothyroidism, fibromyalgia, cardiovascular disease, hypertension, obesity, diabetes, cancer. The multiple subconscious awakening present at the end of each sleep apnea, preventing the establishment of a structured sleep, increase the risk by 6 times of having a metabolic syndrome in children with obstructive airway disorder. This metabolic syndrome corresponds to the presence of a set of physiological signs caused by impairment gas exchanges, systemic and pulmonary arterial hypertension, increases triglycerides and cholesterol, as well as insulin resistance. People with metabolic syndrome are at a higher risk of developing diabetes and are more prone to cardiovascular disease. Cardiovascular consequences, heart rhythm disturbance, and ventricular dysfunctions are noted in approximately 15% of children with obstructive airway disorder. So what's really happening? What's the underlying cause? Is there a compromised airway involved? What other signs and symptoms the dentist can identify? Is there a narrow dental arch, tooth crowding, high volt palate, tongue tie, parafunctional habits? Are there other issues that needs to be addressed? Does the patient have a weak tongue, low tongue position, weak oral facial muscles? Is the patient presenting abnormal growth? Dark circles under the eyes, looking tired, narrow and small chin, dry lips, mouth breathing, lack of symmetry, looking sad. Are there symptoms linked to a compromised airway? Parents are the first to notice a problem with their children breathing while sleeping. Sometimes it's the pediatrician who notices a problem in the growth curve or weight gain. The dentist also can notice warning signals, such as the shape of the face, like a long face, mandibular heterognathia, macroglossia, large tonsils. We need to investigate the airway and not just look at teeth. What could be causing the compromised airway? Airway obstruction caused by underdeveloped jaw can cause many health issues and will need to be addressed by a team of healthcare professionals. The dentists need to search through a detailed questionnaire and examination of all the risk factors for obstructive airways. He will then refer the patient to specialists such as ENT, otorhinolaryngologist, or pulmonologist, a sleep doctor, to do further investigation of the nose, nasopharynx, and for a sleep test. Are there enlarged adenoids, abnormal septum, abnormally in the turbinates, inflammatory nasal sinus, rhinitis? Does he have apnea or upper airway resistance syndrome? Does the patient have a narrow upper or posterior airway that could be the root cause? We need to investigate. We need a CBCT scan to see the whole craniofacial structure and the airway volume. How did it get this way? Is a narrow upper or posterior airway preventable in children? Is it treatable in adults? We dentists are again in the front line of these questions. We must work towards identifying and treating the root cause of the problem. It is the dentist who can then address the treatment and expansion of the arch and of the narrow airway that could be causing all these symptoms. In the 21st century, we now have the tools to do it in a non-surgical and non-invasive way. This is a case report to illustrate an integrative multidisciplinary approach to sleep disorder breathing. The patient's features were covered to preserve their identity. The main complaint was excessive tiredness, lack of concentration, and severe daily migraine. We want to assess our patients like we use our photographic camera, not starting with the teeth. We want to start by observing their bodies. We look for body posture and postural compensations. We start to see some alteration on his posture. Next, we examine the craniofacial profile. We can see the venous pooling, the dark circles around the eyes, an asymmetry of the face. There are postural compensation of this patient to open his airway, trying to breathe. Could that be accounting for some of these symptoms like his daily migraine? We examine the patient's profile. We analyze the proportions and symmetries. We look for facial asymmetries and measure their facial proportions. We make a thorough assessment of their features. We analyze their vertical plane. Only then we move on to the upper airway evaluation. We start with an extra-oral assessment. How are their nasal aperture? Is there a neck deviation? We now move to the upper airway, intra-oral assessment. And as part of the assessment, we carry out a CBCT scan to look at their airway volume. We need to look at TMJ. Is there any deviation? Is there any bone degeneration? All of these need to be part of our investigation with good quality images. Only then we look inside the mouth. We do our intra-oral assessment where we classify any malocclusion. And we record any relevant information such as previous orthodontic treatment or extractions. We carefully note any relevant signs. We look at the vertical and horizontal plane and do the midline assessment. Next, we take intraoral photographs and scans, including any relevant images. We zoom in further to do our soft tissue assessment. We look at intraoral mucosas, any sign of soreness, redness, dryness, or signs of oral cancer. We do our frenum assessment, upper, lower lip. An important part of the evaluation is the tongue tie assessment, the tongue function and nose breathing investigation. We take measurements, pictures, and videos. If we need a tongue tie release, we can start to think about our teamwork. Who will release it? Who will do the myofunctional therapy? We assess for parafunctional habits. We look for signs of atypical swallow. We also check for mouth breathing. If the patients have a reverse swallow or mouth breathing, we must reestablish proper function and need to start to think about myofunctional therapy. We now move on to the airway and sleep evaluation. We do a complete airway evaluation using CBCT scan, where we measure the airway volume and look for any obstruction. we look at the cephalometric analysis. And now it's time to look at the sleep test. This is a sleep report of one of the nights of this patient. It's well known that sleep disorder breathing gets worse over time. In this case, the patient is only 25 years old and is getting already a very bad quality of sleep. He presents severe apnea-hypopnea index. Over 50% of his sleep should be stable or deep sleep, but he's only getting 31%. He spends 37% of the time with an unstable sleep. This is more than the maximum expected of 30%. His sleep is very fragmented. No wonder he's always tired, despite reporting sleeping for over 90 hours a day. Once the records are uploaded to the clouds, a team of Airway specialists will help to analyze the recorded data. And an Airway intelligence report is generated. The Airway intelligence report will include health history, CBCT evaluation, photographs, intra-oral records, and his sleep report. And the comparative of all his craniofacial measurements with the normal limit standards. These reports can be used to present to the patient in a concise and visual way, and to the team of selected healthcare providers that will be working in his case with us. Now is the time that we're planning. At this stage, we can start to think about the group of healthcare providers we want to work with us. We need the tongue tie release. We need myofunctional therapy. We need to see an ear and nose, throat doctor. We need to be seen a chiropractor or an osteopath. We need an allergist doctor, a pulmonary sleep doctor to look into his sleep study. Should we refer him to a neurologist to check his migraine? So this is all integrated in our treatment plan. As we look closer, we can start to correlate his symptoms with his findings. For instance, his occipital atlas distance is around 5 millimeters, when it should be around 10. Could this be accounting for his daily migraine by pressing down important structures? His left condyle is very posteriorized. Could this also be influencing his migraine? We also think about at 25 years old. At 25 years old, this patient is already presenting bone degeneration on the left condyle head with beginning of beaking. You can visualize the craniofacial discrepancies and start to think of possible vertebral deviation for compensation, and be already planning for the involvement of chiropractors or osteopaths for the evaluation and concomitant treatment of this patient. His soft palate length is 42 millimeters. That's 7 millimeters above what the average should be. This will be a factor that can be accounting for the obstruction of his airway, and we need to work with the ENT doctor. We may want to consider treating him with night laser, low power laser treatment that improves the elasticity of the soft palate whilst we are undergoing expansions of the airway. The ENT doctor will need to evaluate him for septal deviation, nasal space, and possible allergies. Forward head posture is common on patients with obstructive respiratory disorders. This position is adopted in order to facilitate breathing and is common in mouth breathers. Studies have shown a return to normal in patients with treated enlarged adenoids, in patients with reestablishment of physiological nasal breathing and adequate tongue positioning. This emphasizes the importance of multidisciplinary team approach, where we work closely with the ENT doctor, the chiropractitioner, the myofunctional therapist, and so on. The patient was sent for a chiropractic evaluation and treatment of compensatory misalignment. He provided a detailed report on his condition and initiated treatment in a coordinated way. This is part of his detailed evaluation report. I will not go into details, but it's important to see how a teamwork approach can improve the health of our patients. He made a detailed analysis of the problem and sent me the report in writing. The patient had postural compensations and some rotated cervical vertebrae. After the first adjustment, the patient already reported improvement in his migraine and neck tension. The treatment plan for this patient involved a team of healthcare professionals with dentistry at the core. The team comprises of the dentist, me, as the core provider for craniofacial and airway growth, and for the tongue tie release at some point. For the growth, a biomimetic removable intra-oral appliance, FDA approved for the treatment of obstructive sleep apnea, is being used. This is a non-invasive option that treats the root cause of the obstruction. We chose to work with a chiropractor and osteopath for cervical and body realignment, the ENT doctor for treatment of allergy desensitization and evaluation of nose obstructions, the pulmonologist, sleep doctor for the full sleep disorder evaluation, myofunctional therapist to reestablish tongue and breathing function, a functional doctor, a nutritionist to check his long history of low BMI and reestablish his overall health, and a neurologist for a full evaluation of his migraine. In 3 months evaluation, so far, patient has drastically reduced the recurrence of his daily migraine, has gained some space for his tongue, as we have seen some growth of the upper arch as the removable intra-oral device is gradually adjusted. He's getting some space with his expansion. Although it's only 3 months, we can see his deep bite being gradually reduced. There is still a long way to go, but his profile has greatly improved. His forward neck posture has been reduced. He gained some color and is starting to look healthier. And overall, he seems a happier patient. There are other approaches and forms of non-invasive treatment for obstructive sleep disorders, but they are palliatives as they don't resolve the cause. They involve the use of CPAP, continuous positive airway pressure, or CPP, or mandibular advanced devices. There is a silence crisis in the Western world. In the left-hand column are signs and symptoms typically found in children. Research has shown that 4 in every 5 children in USA suffer from one or more of these conditions. And on the right, there are signs and symptoms typically found in adults. Research shows that in general, about 9 out of 10 Americans suffer from one or more of these conditions. It's time for dentists to look beyond teeth. There are lots of opportunity out there that we could be using to help our patients. So my takeaways is I mentioned so many treatments here, and rarely the word teeth. Are we really only doctors of teeth? Are we using everything we know to care for our patients? Are we seeing our patients as a whole or just a mouthful of teeth? It's time for dentistry to change. What's your role as dentist in the 21st century? If you want to change the way you do dentistry, you may want to implement integrative orofacial medicine in your practice and join the sleep medicine revolution. You might want to start using photonic devices, treat patients with oral cancer and patients with chronic pain. The time is now. Everyone who wants any extra information, please feel free to email me. I would like to invite you to visit our websites. We run training on all aspects of integration of new technology into the practice. We have a specialized support line to help you define what's the best training for you based on your practice need. Anyone who wants any extra information, please feel free to contact me. A lot of what I learned in integrative sleep dentistry, I owe to the various training I have received. There will be another 2 major events in sleep medicine in November and December, which I'll be participating. I have learned a great deal from the Airway summits. If you are interested, I highly encourage you to participate. I've managed to request a code for the attendees of this webinar specifically to get free entry to these events. So if you are interested, please take a screenshot of the screen. This webinar will also become permanently available at the end of the presentation, and you can also register on the link below to get CE credits. And now I will leave you with a very short video on the link between sleep disorder breathing and ADHD, and we'll come back after it for your questions and answer session. So stay tuned, and thank you for listening to me.
Now take a child, alter their quality of breathing and sleeping. And the real big issue now is how will they be during the day? So now you take a child who's 5, 6, 7, 8, it doesn't matter. Their issue has begun years ago. So it's not like you had 1 or 2 bad nights of sleep. You've had a poor quality of sleeping and breathing for years. And the parents have been struggling with so many different issues, and not the least of which is the ADD, ADHD discussion. Because the child who doesn't get a proper night's sleep with a good quality of breathing throughout the entire night is going to wake up and be unrested. And when you get a child who's had a poor quality night's sleep, poor breathing all night long, and you make that happen for years, you know what you've got? A 6, 7, or 8-year-old that's going to go to school and have trouble learning, have trouble sitting still, have trouble behaving, have trouble cooperating, basically have trouble fitting in to what is supposed to be a quiet and peaceful and learning environment. And it's not long after that where the phone call comes to the parent. And when the phone call comes to the parent from the school, what happens is, we have little Jimmy here and he's a little bit disruptive and we really want you to have him evaluated for ADD and ADHD. They're going to be diagnosed with ADD and ADHD, and our solutions are pharmaceutical. If we are given a pharmaceutical, it's usually in the form of some sort of a stimulant. And what that does to the child is it kind of pushes them over the edge and it brings them back to calm. So you basically take an excited or hyperactive child, you stimulate them more, and you bring them back to so-called calm. But it doesn't make a better learning child. You're not going to have a child who's able to learn as well. So now you might have the child sitting still in class because they might be a little more numb or relaxed or calm, but it doesn't necessarily make them a better learner. If we have the so-called ADD, ADHD diagnosis, we're talking about hyperactivity. We're talking about all of the things about behavior and development that land in this category. And the interesting thing about research is, and there is current, ongoing, and past research that shows, children who are sleep deprived produce the same exact symptoms as kids who are diagnosed with ADD and ADHD. In fact, there's a nice study that showed children who were diagnosed with ADD and ADHD were mixed with children who were sleep deprived. And in that group of kids, when they tried to analyze them and look at their symptoms and diagnose them, they couldn't tell them apart. And if you have a group of kids and you can't tell apart who's an ADD child and who's a sleep deprived child, it's no surprise that maybe the ADD and ADHD has a cause. And maybe that cause has to do with the quality of the breathing and the sleeping overnight. And there's a lot of research out there. And one of the pioneers here is Dr. Stephen Sheldon out of Lurie Children's Hospital in Chicago. And he does a wonderful job of researching, and over the decades, he's come to a conclusion, and I've seen him speak, and it's not soon after he jumps on stage and he makes a statement that ADHD and ADD do not exist. They are an outcome of a sleep disorder breathing. They're an outcome of a poor quality of sleep. It's all about the quality of sleep. Another researcher who's produced beautiful research on the same topic is Dr. Karen Bonik out of Einstein at Yeshiva University. Dr. Karen Bonik has the largest study to date. 11,000 children were watched over 7 years. And they were divided into two groups, sleep disorder breathing children and children who do not have sleep disorder breathing issues. The children in the sleep disorder breathing group, over their 7 years, her study showed that they were 50% more likely to be diagnosed with an ADD or ADHD diagnosis and treated with medication. 50% is a coin toss for our child to be diagnosed and treated with a medication. Also in her group, they were doing testing. They were doing IQ or intelligence testing along those 7 years. And the children with the sleep disorder breathing, their intelligence testing, their IQ scores were dropping over those 7 years. And that's really not the way it works when you're growing and forming. The formative growing years for a child, when they're sleeping and breathing well, your IQ raises to a certain point and then you kind of plateau. We don't see IQs diminishing amongst children.
All right. I think you muted. Okay.
Well, thank you so much, Dr. Sonia, for such an informative session. It was actually an eye-opener for, I think, all the fraternity in the field of dentistry, that we are not only limited to teeth, but we are definitely limited to the complete, you can say, the head and neck region and the complete body, you can say the medicine or probably how the functioning is there. So it was really a deeper insight. And I have a few questions for you, Dr. Sonia, right? You have talked about bruxism, right? That bruxism is one thing. So what is this, what we know about the deprogramming? How exactly it is helpful in the child to take care of this bruxism, or in adults that we can take care? The deprogramming, what we do generally.
Basically, more and more research are coming out now showing that bruxism is actually a mechanism of the body in trying to open the airways for children with, for people with obstructive airways. So not only in the night, but also in the day, a lot of mouth breathers. So is a lot of new research coming out in the literature. For many years, we always thought it was just related to either anxiety or other reasons, malocclusion, but now is a big link related to airway. And we have seen this in patients when we treat with the expansion of the airway, that we get the bruxisms to stop. So this, we are seeing this on a daily basis with these patients that we are actually treating and improving the airway. So I think that one thing I've learned, I really feel bad how I did dentistry 30 years ago, but at the same time, I feel I'm happy in the 21st century too, because a lot of things you just have to relearn. And so much is coming out. And I have a lot of colleagues that are getting to sleep medicine, and many times they say, but my patient say to me, doctor, I came here for perio. Why you want to look at my airway? And that apparently put them a little bit off of doing other things that they were used to, because they think the patients are going to think it's strange, a dentist doing airway. But all they need to do is to show them the American Dental Association recommendation that all dentists should be screening for airway. And one of the problems of the root cause of the airway obstructive sleep disorder breathing is the the smaller growth of our maxilla and mandible. So we are being pushing backwards and backwards because of our Western culture habits. We're not breastfeeding enough. We're giving soft food to our kids. We're missing out a lot of tongue ties. And this is a myriad of reasons why we should be actually telling this patient, hey, you are lucky I'm looking at your airway, and not to be scared of them wanting to go away from us offering it to them. I don't know if I answered your question.
Yeah. So there's another question, like, is there any specific age in which we can diagnose a sleep apnea?
Absolutely not. We start as early as babies. We now have a special ring that we can use in little babies. Do you know the cot death? There's a huge link of cot death with sleep apnea. Those babies are dying because they have sleep disorder. So this is an epidemic. And yes, we screen patients from any age, and we treat patients from all age group, from baby all the way up to 90 years old.
Right. So is there any specialized imaging technique that you recommend that the dentist should go for when they are okay, this is one imaging that is must to diagnose that sleep apnea or this thing?
Yes, you definitely need to be able to see the airway volume and everything. You really need the CBCT scan. It has to go from the top of the head, ideally to C5 or at least C3. So we need a full CBCT scan, which we can then measure. And from that, you can see the whole system. You can see the airway and the nasal airway. You can see the oropharynx airway, everything. So yes, that's what we use as our standardized image. And then we always do the sleep tests too. But many times the sleep test can show no apnea, hypopnea index, but it shows upper resistance airway, like with a high RDI, which is that patient is still suffering, but because they don't spend 10 seconds without breathing, they're in the apnea index is low, but they still can have a huge fragmented sleep throughout the night.
Awesome. There is one thing people are always confused, like we should go for a CPAP or a BiPAP. Always there is a confusion, like CPAP is for sleep apnea or a BiPAP for a sleep apnea. So how you differentiate exactly that which is recommended?
Well, for me, normally is the doctor, the pulmonologist or sleep doctor that actually would work recommending the CPAP or BiPAP. To me, I don't like thinking about palliatives. If my huge philosophy is to treat the root cause and try to expand this airway, which you can do now with the biomimetic devices, and it's the dentist who can do it, nobody else. If you go to a doctor, all he can do is to say, okay, put you on a CPAP forever. And it's well known now that even if you're with a CPAP, patients gets worse over time. So if you start with a 40 index, in a few years, you may be with a 50 or 60, and you carry that thing forever. So the main objective is to understand that we dentists are the core of this. We can provide solution. we can provide the definitive treatment. With nothing against CPAP, some people might not be a candidate or might not want to try intraoral expansion. But we need to be at the front of this, because we are the only one who can actually treat this condition permanently. Yes, there is CPAP, the mandibular advanced device, which eventually can cause problem with the TMJ. So to me, I don't like to work with those, but many times as you refer to the doctor, this is your alternative, that's what you have to do. For some reason, they're not a candidate. Many times they're not candidate for our treatment. So they end up having to go but that specific, what is better for each patient, that's normally is the medical doctor who will define.
So what are the different ways of the myofunctional therapy what exactly you recommend that the doctor should advise to the patients, especially when they are in the sleep apnea?
To me, myofunctional therapy has to be part of the team, all the time. Why? Because a lot of these patients, they are mouth breathers. They have not been breathing through their nose for years, because they, for whatever reason, they having a dysfunction there, an obstruction. And even if we expand this patient needed to relearn how to go back to breathing through their nose and how to swallow properly. They need to have their whole tongue on the roof of their mouth, not just the tip, not just the two first thirds, the whole tongue. And that's our, the tongue is what is the function that reshapes the form and that holds that form that we finalize with our treatment. So yes, swallowing and nose breathing is fundamental. And I think you saw one of my slides that showed the patient goes back to their posture. It's like the body knows I don't need to compensate for breathing anymore. So function is everything. And every patient I work with, I work along with myofunctional therapy. So I recommend that.
Well, thank you, Dr. Sonia, for your wonderful session. And it was actually, again, a pleasure and honor for us at the Global Summit. We are happy to have you as a part of our team. And you had always been encouraging and supporting to us. And it was a wonderful evening with you, to sharing the views on the integrative part of the oral medicine, I think, which is one of the most important part, which is missed, I think, by most of our fraternity. Thank you once again, ma'am, for your very informative and interesting session. And thank you. And we hope to look forward to see you soon for more webinars. Thank you so much and have a great day.
Thank you. Same to you. And thank you for the opportunity.
Thank you, ma'am.
Bye.
So we'll sign off from here. Thank you, everyone.
Thank you. Thank you.